My name is Jonathan Perlstein. I lead enterprise marketing here at Virta Health, and super excited to have you all join us today, as well as our wonderful group of panelists to discuss the iron triangle of digital health, validation, ROI, and sustainability. So I have to admit, the title of this webinar is a bit of a wink and an homage to my grad school professor, Lawton Burns, who is a health economist at University of Pennsylvania, who always spoke of the iron triangle of healthcare being cost, quality, and access. For today's conversation, we've updated the iron triangle to focus on three things that are truly essential in digital health, but unfortunately often in very short supply. And so let me talk about each of the three items before I introduce our panelists. So the first is validation. Validation refers to demonstrated clinical outcomes validly measured through a defensible methodology. Obviously critical in digital health, vendors all too often are making wild claims that are not backed by rigorous analytical methods, and we're excited to have some of our experts here from Validation Institute to talk more about that. ROI, an area, again, where vendors are making bold claims, but also often on very thin evidence. The challenge here for employers and payers is to make sense of what is real versus what is marketing puffery. And then finally, sustainability, perhaps the most elusive feature of digital health solutions. The question here is, can digital health really deliver outcomes and savings that are sustained over time through ongoing engagement through patients and through members? So those are some of the big, meaty questions we hope to address today, and what we'll call, for the sake of argument, the new iron triangle. So if we go to the next slide, please, I'd like to introduce our first two speakers. We have Benny DeCecca and Linda Riddell from Validation Institute. We'll kick things off with a quick announcement around their newest gold standard of validation. Let me give their brief bio. Benny is the CEO of Validation Institute and Think, the healthcare innovation company. Before Validation Institute, Benny led the Wellesley Information Services as a CEO for 17 years. Thank you, Benny, so much for joining us today. And next we have Linda, a population health scientist, educator, and validation expert. With over 30 years of experience in healthcare, she's an industry expert in measuring outcomes for health and wellness programs, and she serves as the VP of Population Health at Validation Institute. Welcome to you, Linda, as well. So that's it for my introductory spiel. Benny and Linda, over to you.
So I'm going to kick it off and talk a little bit about Validation Institute and what we do. Validation Institute vets and validates the claims that healthcare product and service providers are making with regards to performance. So whether it is saving a company money, reducing risk, or creating a healthier population, we make sure that sellers are being transparent and accurate so that employers can be reassured that what they're being told is true. We have two types of validations. The first one is claims and measurements. There are four categories that we look at: savings, outcomes, contractual integrity, and metrics. So an example of a claims and measurements validation is Virta recently was validated for reducing drug spend by over $180 per member per month in year one and $280 per member per month in year two. The second type of validation we have is the highest level that a healthcare company can achieve, which is a program validation. Now, a program validation is when a company runs a qualified study, such as a random cluster randomized trial, and we're able to validate the study and findings. Now, once a company achieves this type of validation, which is very difficult to do, we will put a $50,000 credibility guarantee on the validation. So if an employer does not achieve what the validation states, they can put in a claim for up to that amount with the Validation Institute. So we stand by our validations. So Jonathan and team, we're very excited to report that the team at Virta is the very first company to achieve this highest level of validation for their diabetes reversal program. So congratulations to you and everybody on this outstanding accomplishment. And so now I'm going to turn it over to Linda Riddell, who will explain to you what this new level of validation means for employers and health plans. Thank you. Linda?
Thank you. I really appreciate what Jonathan said about evidence being in short supply in the digital health realm there. So Validation Institute created this higher level of validation to recognize programs that have the strongest evidence of their effectiveness. So what does that mean? Many companies have data about people who have enrolled voluntarily. So we call those observational studies. They are observed and tracked over time. The results of that type of analysis speak strongly about the persons enrolled, especially if it's a voluntary enrollment. Whereas stronger evidence comes from programs that have randomized the enrollment. So the results are about the program and less about the eagerness and willingness of the people who enrolled to participate. I hope that kind of makes sense. But for employers, what this means is that this level of evidence tells you about the strength of the program rather than evidence about the type of people it attracts. So it's about the program's effectiveness and not the enrollment. Not to say the enrollment, would be low, but I'm just trying to differentiate between what the evidence is speaking about. So as Benny said, we're very pleased to have validated Virta's analysis that they did with the Indiana University Health System. I'm very pleased to be here today to answer questions. I think it's back over to you, Jonathan.
All right. Perfect. Well, thank you, Linda, and thank you, Benny. We're super exciting news. We're very proud, again, of getting that recognition from your team at Validation Institute around the evidence that supports our claims around diabetes reversal, and continuing to build the scientific and clinical evidence foundation for what we do. All right, so next topic is around sustainability, the next point on the iron triangle. And for that, I want us to move over to our next speaker, Dr. Frank Dumont, the Commercial Medical Director here at Virta Health, who will talk through our 5-year outcomes. So not to be a spoiler, but I think Virta is quite unique in having such sustained demonstrated outcomes in our patient population. But I'll have Frank talk more about that. Frank will talk about some of these data that we recently shared at the American Diabetes Conference just a few months ago. So Dr. Dumont, over to you.
All right. Thank you very much. Well, first, just to let you know a little bit about me, I'm an internal medicine physician by training. So I take care of patients in adult medicine realms. I've been practicing for 25 years, most of that as a primary care physician. And so I spent a lot of time taking care of patients with chronic disease like diabetes and watching them get worse. In fact, I was trained to be a medical pessimist. I was basically taught that people could not make significant lifestyle changes and that we really shouldn't expect to see much positive when it came to diabetes. We should be expected to see people decline. And in fact, there was very little in my first 20 years of practice that led me to believe otherwise. In fact, one of my first patients that I took care of was a man named Lyon. He was a Native American, worked at our hospital in the environmental services section. I saw him every day as I was walking into clinic. He came in to see me as a new patient. We looked at his laboratory studies together, and what it showed was that he had very uncontrolled diabetes. He was at very high risk for diabetes complications. And so being taught as I felt like the thing that I needed to do was get him on more aggressive medication therapy. So I told him we needed to start insulin that day. Now, he became quite emotional when I did that. And I queried, I asked, why is this affecting the way that it is? We need to get this under control. He told me that every single member of his family, and there had been many who had diabetes and had been placed on insulin, had quickly died of their diabetes within a matter of years. Now, in spite of that, we spent more time talking, and I did convince him to take insulin. But then over the next few years, I watched him go through that exact course that he had predicted, where he started to have complications, problems with his vision. He underwent an amputation surgery. He ended up ultimately having kidney failure, and he died an early death because of diabetes. That was the kind of thing that reinforced my pessimism. Now, what I do now at Virta, what I've been doing for the last 4 years is very different. In fact, I'm seeing people have entirely different outcomes. I spend most of my time taking away medicines that are not necessary anymore. And the thing that ultimately led me to that was the data. It was looking at the science that was coming out from the clinical trial that Virta started with Indiana University Health and seeing what they were able to accomplish and convincing me that there was another way to do this. I wish that I'd have had this to offer to Lion back 20 plus years ago. So it's my privilege today to talk to you a little bit about some of the newer data that we've been able to present. As Jonathan mentioned, we presented recently at the American Diabetes Association conference in June. We were showing our data from our clinical trial and also some other data with regard to patients from the VA Medical Center. So I get to highlight some of those and talk about the clinical outcomes, what that means in terms of ROI, and then also what that's able to show in terms of sustainability of a lifestyle change, a nutritional approach to reversing diabetes. So if we could move to the next slide, please. I want to start out by just contrasting this situation with what is traditionally out there. When you look at diabetes and pre-diabetes solutions, we don't have long-term outcomes in general. Most things are either new enough or they haven't been studied carefully enough to be able to try to answer this question of sustainability. Our clinical trial with Indiana University Health was actually designed to be a 2-year study. But once we reached the 2-year mark, we realized we needed to take this further. And so we actually pushed it out to another 3 years to get to 5-year data. And so we're the only entity out there in terms of diabetes and pre-diabetes, which is actually able to show what we've been able to accomplish clinically at 5 years. Next slide, please. So a couple of highlights from that study. First, I want to talk about diabetes control. And one of the ways that we measure this is with something called the A1C. That's a marker of what the average sugar levels have been. Now here, what you can see are 2 bars indicating baseline data, what happened, what the numbers were for the individuals who started at the beginning of the clinical trial with Indiana University Health, and then at 5 years. Now these are ranges of A1C. So the higher the A1C is, the worse the diabetes control. And when you look at the tan and the red on the far right, those are individuals who have poorly controlled, uncontrolled diabetes or very uncontrolled diabetes, an A1C above 8 or above 9. That's where the risk of complications, like my patient Lion experienced, are very, very high. Now, in contrast, when you get into the green, those are people that have subdiabetes A1C levels. And when you start to get into the dark green, that's diabetes remission. These terms have been defined recently. So reversal is getting to a subdiabetes level off of all medicines other than metformin. Remission is subdiabetes level A1C and off of all diabetes medicines entirely. And what you can see here is that at 5 years, so after people have been working on this for this long, that 33% of them have been able to achieve and sustain diabetes remission or reversal. That's truly significant. That makes a big difference in terms of where they're headed metabolically and their outcomes. And what that also means is coming off of medications. So to be in remission or reversal, we're stopping medicines, and that makes a significant difference in terms of the cost for the patient, but also for the employer or the health plan. Next slide, please. Now, when you look at 33% of those people achieving that and 20% of them achieving that rigorous definition of reversal, you can see how much better this does than what we have been taught to expect, what I was trained. If you look at the Look Ahead trial, this was an intensive lifestyle group, low-calorie Mediterranean, low-fat, what I was primarily trained to teach people to do. We see very, very low rates of remission happening, and we certainly don't see them in a sustainable way. But at Virta, with this approach, with the level of support that we're able to wrap around our patients using technology, and with this particular nutritional science-backed approach, we see these rates of remission of 20% at 5 years, which is really remarkable. Now, where can you see comparable results? Well, in the next slide, you can see really what our, quote, competition is. It's bariatric surgery. So here we're talking about invasive, aggressive, and costly and side effect prone procedures to try to achieve this type of outcome. So you look at gastric bypass surgery, where we're actually skipping over part of the stomach and part of the intestine so that you can't absorb nutrients. That can achieve diabetes reversal, and in a rather sustainable way. So it's comparable to what we've been able to do. But again, we're doing this with nutrition, trying to address the root of the metabolic problem, insulin resistance, carbohydrate intolerance. So that's really what's comparable, bariatric surgery. Next slide, please. Now, a couple of other highlights in terms of just the data from the 5-year presentation. First of all, the retention. the ability of people to do this for the long term, because this is one of the questions that we're often asked. Now, when we reached the end of the second year, we asked patients if they wanted to continue with the treatment. 75% of them said that they did. That's already remarkable. Most lifestyle interventions, they're at best 15 to 30% adherence and retention at 1 year. Here we were 2 years in, 75% of the people wanted to go even further. And of those, 72% of them were able to continue for that additional 3 years to get to that 5-year endpoint. That's remarkable retention for a lifestyle program. It shows that what it's doing for people is tangible. They can see the difference, they can feel the difference, and they want to continue. Now, here are a couple of other pieces of data from that publication or from that presentation. The average A1C, that marker of diabetes control, was 0.3 below baseline, even out to 5 years. So still below what their starting point was. And what we know is that with traditional care, not bad care, but traditional good care with PCPs, endocrinologists, that A1C climbs every year. It goes up a little bit every single year in this progression, in spite of adding in more medicines. Now, in contrast, that delta from where they would have climbed to and that 0.3 below baseline is truly significant at a period 5 years out. And the thing that's even more exciting about this is that's being done while stopping diabetes medicines and keeping them off. So instead of adding in more medicines every single year, as we saw in the control arm of that study, we were able to decrease medicines quickly, but 60% of those diabetes-specific meds were still off of that list. They were still not necessary for those patients at the end of 5 years. That's sustainable clinical impact. And then finally, one other thing that I just have to touch on is the weight loss. We're not focused on weight loss per se. We're focused on metabolic health. But the way that we address metabolism helps people lose weight in a more sustainable way. We know that most weight loss programs, 50% of people have fallen off of that program by 3 months. Now we're talking about 5 years out for our data, and what it's showing is that the weight is still 7.6% below the baseline weight. 5% is clinically significant. So to be this far below baseline at 5 years, again, shows how impactful this is and how sustainable it is from a weight loss standpoint. All right, and I'm going to change gears just a little bit to talk a little bit more about weight. This was from our prediabetes population within the trial. So again, 5-year data, looking at the amount of weight loss that people were able to achieve and sustain. And again, remember that benchmark, 30%, at 3 months, 50% of people have left most weight loss programs. In contrast, here we are at 5 years, patients with prediabetes, they're not even coming off of medicines. They're just addressing metabolic health, losing weight, and feeling better. And it looks, and what it shows is that about 20% of them have lost 5 to 10% of their body weight. So clinically significant. Another 19% have lost 10 to 20% of their body weight, and actually more than 20% body weight loss for 10% of the individuals at 5 years. Again, this is the kind of thing that I was told did not happen with lifestyle programs when I was in training. The data would say otherwise. All right, switching gears one more time, I'm really excited to share with you also some of the data that we were able to present at the ADA conference around a more challenging group of patients that we've had the privilege of working with. We've been working with patients from the VA Medical Center for the last few years, and we've been tracking our outcomes with them. And the reason this is important is because this is a more challenging group. In central Indiana, it's a more homogeneous group. These are people that we've been told are perhaps more eager to take on lifestyle change. Well, the veterans have a lot of underlying medical problems, underlying psychiatric conditions. They've been hard to engage. They've been hard to keep engaged. And yet we've been able to see the same types of outcomes for them in a sustainable way. And so just touching on some highlights here. If you look at that HbA1c, that marker of diabetes control, what you can see is at 1 year that has come down by 0.7 points. And that at 2 years, it's still down by 0.6 points from baseline. And that's while we are deprescribing medications that are no longer necessary to achieve that level of control. So if you look at the bottom row, what you can see is that 51% of those diabetes-specific meds have already been stopped by the end of year 1, and that 41% of them are still not necessary at the end of year 2. So sustainability and really impactful clinical improvement, improved A1C, so improved metabolic control, and also a significant decrease in cost as we're eliminating medicines and keeping them off to year 1 out to year 2. Next slide, please. So this is again showing that range of A1C data for the VA population at 2 years. And just two things I would point out here. On the right, if you look at the tan and the red, that is, again, uncontrolled diabetes, high risk of complications. Now you look at where it is in the bottom at 2 years. That's a decrease by 40%. You're taking 40% of those people out of that very high risk group and moving them into healthier metabolic ranges with the Virta treatment in a way that is sustainable out to 2 years. And again, if you look at the far left, what you can see is that increase in the green and the dark green. What that means again is reversal and remission. These are people that not only now have diabetes control, subdiabetes levels of A1C, but they're not requiring those expensive medications to achieve that. So really exciting to see how that population is shifting to a healthier place. Next slide, please. And just to touch on then one other aspect of the treatment with them, we tracked how people were doing when they left the Virta treatment, when they graduated, so to speak. We don't have an official graduation. Patients work with us for as long as they feel that we're helpful to them. But one of the pushback areas we've heard is that perhaps the people that are leaving aren't doing well, and it's only the people that are doing great that stay with you. Well, this is showing how people were doing when they left the treatment. And what you can see across the board here is that people are doing better metabolically when they leave the treatment, whether they leave within the first 6 months or in the first year or beyond. And you can see that with regard to weight, where the weight is lower than it was when they started, when they leave Virta. Their glucose levels are lower than they were when they started. And perhaps most importantly, with those lower glucose levels, they're requiring less medicine to achieve that level of metabolic control. So if you look at the very far right lower, you can see that for the patients that stayed with us the longest in the VA population, 50% less medication was necessary by the time they left the Virta treatment when they graduated. So that's the data that I have. I wish that I would have had this information and this type of an approach when I was working with Lion 20 years ago, but I'm happy to be able to share this with you now and have the experience that I have taking care of patients now. Jonathan, back over to you. Thanks.
Wonderful. Thank you, Frank, so much. Really appreciate that discussion on sustainability. So next, I want to move to our final speaker, Al Lewis. But before I get to Al Lewis, I guess I wanted to give just a little bit of information about Virta. Of course, we're publishing a bunch of peer-reviewed papers on an ongoing basis. What Dr. Frank Dumont was sharing was our latest research from the ADA. What we had validated, again, was from our clinical trial with Indiana University. And Al will talk about that in a little bit, about the methodology that we use there. So with that, would love to introduce Al Lewis. Al is the CEO of Quizify and is a leading expert on outcomes measurement. He's written the book on it, literally. He founded Validation Institute, which he's still advising, and he's the author of the textbook on outcomes measurement called Why Nobody Believes the Numbers. His book has been featured in the Wall Street Journal, The Incidental Economist, and several times in Health Affairs, and a Harvard Business School case study. Al is well known for exposing invalid vendor claims, which is, I think, one of the ways in which we met, just having a shared enthusiasm for calling out vendors who make unrealistic or untrue claims. And he's also been known to bet substantial sums of his own money against vendor claims that are unprovable. We'll talk more about that. And he'll talk a little bit about the personal bet he's put on the claims that we are making here at Virta. Al, we are very honored to have you join us today. Over to you.
Okay, well, thank you very much. And just to pick up on your last point, I am offering a $100,000 challenge of my own money. That's above and beyond the Validation Institute to any digital health solution that has better results using more valid methodologies than Virta. And I would tell you, don't waste your time. As Jonathan said, my reputation is more about what I've done in the opposite, what I've done to expose vendor outcomes rather than to support them. And he mentioned a book. I actually have written 2 books, Why Nobody Believes in Numbers and Cracking Health Costs, on the subject of measuring outcomes, and been featured in, well, you can see all those journals and newspapers. And most recently, the Harvard Business School wrote a case study that includes my methodologies. So I'm not making this stuff up. So we're going to have some fun. We're going to talk about how not to measure outcomes or ROI. And before we do, I'm going to ask a question. I think actually we have a polling question coming up. I think maybe it's next, but maybe not. All right, let's talk about regression to the mean. This is a favorite of vendors. And I got to explain a little bit about what it is. So this is the baseball standings on April 28th, 1988. And I picked this date because Baltimore set a record by losing its first 21 games. So the difference between Cleveland and Baltimore was 0.762. Now, if you go to the end of the season, regression to the mean, the tendency of samples to become less extreme as sample size increases, the range from top to bottom goes from 0.762 to 0.216. And more importantly, over time, the higher people, in this case, Cleveland and the Yankees, decline, while the lower people, in this case, Milwaukee and Toronto, increased. So that if you start out high, you're more likely to go down. And if you start out badly, you're more likely to go up. Now, this is a fairly obvious statistical thing that happens, and yet some vendors have weaponized it. Now, this is an example from a carrier that you have all heard of. They're big fans of Quizify, which is my day job, so I'm not going to mention any names. Their wellness brochure guarantees that 30% of high and medium risk wellness members will improve, as you can see from that chart. Oops. But there is no mention of the possibility that the low risk people and the medium risk people will get worse. But if you remember, if you look at those standings, that's exactly what happened. Cleveland and the Yankees started out great, finished below 500, while two other teams did exactly the opposite. So let's use an example from smoking cessation. See what happens if you apply the methodology in this brochure. Suppose everyone in your organization smokes and quits in alternate years, and that smoking is the only risk factor. So you have 50% people smoking all the time, but it's a different 50% in every year. Oops. I mean, just a little bit of trouble advancing slides here. If you use that methodology that you just saw, you measure only the people who decline, who quit smoking, you're going to find a 100% reduction in smoking every year, even though the smoking rate remains unchanged. You cannot just measure people who were bad and got better. You also have to measure people who were good and got worse. Let me ask you a polling question. The percent, let's take a quote. Now remember, you just saw that there's regression to the mean in both directions. So this is an actual quote from another carrier. The percent of high-risk members improving will exceed the percent of low-risk members getting worse. So the question is this a valid claim for a vendor to promise, an invalid claim, or you need more information? So let's see what the survey says. And we have an answer. Actually, you know something, let's do this. Let's, while we're waiting for an answer, I think we have another polling question. If there's any other question that comes from the audience during this time, I'll use that to kill the 30 seconds. All right, do we have an answer? Do we have an answer? Well, the answer is that it's actually invalid, but let's see what the poll says. Do I have to click on something here? No, I think you need to do it. Well, in any event, the answer is that it's invalid. I guarantee that the percent of high-risk employees improving will exceed the percent of low-risk employees deteriorating is invalid because there are so many more low-risk employees than there are high-risk employees. And you can see that right here. If 20% of the 130 high-risk improve, that's 26 people. If 10% of the 670 get worse, that's 67 people. This is a classic snooker. And by the way you know that it's a snooker is, note this chart. The bars are all equal segments, but 2/3 of the people are in the lowest third of the bar. If you did that in 8th grade, you get an F. The way the vendor tried to justify this was each one of these little bubbles here represents 10 people. I don't think so. I think it was clearly a snooker. So here's so now actually let's go to the, for some reason the advancing is having a little issue here. So let's now go to the second item, which is participation bias, participants versus non-participants. So this is a famous slide, actually made famous by me. I think the industry would rather hide it at this point. It won the wellness industry's highest award, the C. Everett Koop Award, for how incredibly well the participants performed. You can see the blue line. Well, first of all, they didn't start at zero. That's just a little thing that they like to do, start in an inappropriate place. But you can see that the blue line of participants went up much more slowly than the red line of non-participants. The conclusion they reached was the program did a great job with the participants. However, if you look at the slide more carefully, you can see a smoking gun that undoes the entire wellness industry. The first 2 years, the first 24 months, they separated the people in 2004, but they didn't start the program until 2006. And guess what? The participants had already dramatically outperformed the non-participants, because that's the nature of being a participant. This is a smoking gun. And the way you know this is that they actually tried to hide the slide after this, but I had taken a screenshot. I always say the beginning of the end for the wellness industry was when I learned how to take screenshots. So the rules for participants versus non-participants is it will always overstate actual impact. And this includes whether the participants are passive or matched or propensity scored, whatever you want. Participants will outperform non-participants. In case a vendor disputes Rule 2 or Rule 3, see Rule 1. Now we're going to do versus trend. Whenever you see the words versus trend, throw it out. Okay, this is a perfect example. It's all published. This is North Carolina Medicaid. They drew a trend line, and they did this patient-centered medical home, and they predicted that it was going to cost $201 per Medicaid recipient per month if they didn't do the medical home, whereas the actual was $163. You don't have to look at those. What I'm going to do is I'm going to take those two sets of numbers and put them in a graph to be easy to read. So here it is graphed up. Inpatient went down, outpatient went down, emergency room went down, everything went down. Well, those of you who've read my book might remember the line, if you insulate your house, you'll save money, but you won't save money on insulation. So the question is, where is the insulation? Where are these people getting their care? Well, the answer was very simple. One of the consultants involved said, the choice of, what's wrong with this thing? The choice of trend determines the savings. So if you want more savings, you simply pick a higher what would have been trend, and guess what? You'll get more savings. And the way you know this entire program was fabricated and eventually was thanks in part to this analysis, was taken out, was that they claimed massive savings in babies, but babies weren't in the program, nor was neonates, nor were there was no birth control, there was nothing. And yet somehow, even though they weren't in the program, they saved a massive amount of money. This happens all the time. So how many people, but there was a before question here, I don't know what happened to it. How many people think their vendors, other than Virta and Quizify, measure validly? And while we're doing this, this polling, are there any questions that have already come in that I can answer? Anything? Do we have the poll going up? All right. Well, the answer is that most of them don't measure validly. Now let's talk about how you do measure validly. There are three ways of doing it, and parallel assignment will break into two different ways. One is parallel assignment, meaning you actually do controlled trials, as Linda was talking about. The second is you compare event or procedure rates across the entire population. And the third is you use a waitlist control. And Virta had examples of two of these. So there's only been actually one RCT done in wellness or pre-diabetes that before the Virta one. And it was by a wellness company that specialized in genetic testing. And you can click through and find out all this stuff. Now, what was curious about it is they did both an RCT and participants versus non-participants on the same group of people, So they split the population into a control group and then a group that they were going to invite, all based on claims data. So it was a parallel assignment into control and to be invited. And then they invited the people in the to be invited group, and some small portion actually completed the program. So let me put that in a graph for you. Groups 1 and 2, the program groups at the top, were the control population, and they came together into the group that was to be invited. And then I'm sorry, did I say control population? They were the group to be invited. And then the control 945 is on the right. Now, the RCT, parallel assignment, is you compare the control group to the to be invited group before you actually send out invitations and get people into the program. Now, if you did that, the published result was that basically, in the immortal words of Jerry Seinfeld, it was about nothing. Nothing happened. These were 6 variables. 3 of them, the first 3 did slightly better in the invited group. 1 of them was slightly statistically significant. 3 of them actually did worse in the invited group than in the control group. So nothing can happen. These are trivial changes over the course of 1 year. It's not going to affect anything. However, if you, as they did, compare the control group to the group that actually sweated out the program and finished it, you get, drum roll please, massive savings. Massive savings. They saved $1,464 a person in the first year. Oh, I left out this little detail. These people were picked because they didn't already have diabetes or heart disease. So they had no diagnosed disease to begin with. They just had risk factors. So there's basically, there's no way you could reduce admissions or insulin use or anything like that. And yet somehow they save $1,464. The reason the savings are so high is that in this industry, you have to show a 2 or 3 to 1 ROI. And this program costs $500. So they had to make up a much larger number in order to justify it. A member of the Journal of Occupational Environmental Medicine who saw this publicly apologized for allowing the journal to publish this result and bury the other result in a footnote. So this is same people, same company, same everything, the difference between doing something validly and not. And by the way, just so everybody doesn't think that all vendors are horrible, there are some that have been validated by the Validation Institute for different things. And I'd encourage you to read the validations because there's some legitimacy. And by the way, I didn't put Quizify up here. Quizify has the highest level of validation as well. So that's parallel assignment. The next thing you can look at is the total event or procedure rate across the entire organization for specific things that you're looking at, like diabetes admissions or something like that. There's no regression to mean because you're including everybody. There's no participation bias because everyone's events are measured, whether you knew about them in advance or not, or whether they participated or not. And there's no versus trend because these are all done on the basis of units. So to determine what your event rates are for common chronic, you count the number of event rates, medical events for each category, and that would be ER and inpatient, because it's like a defect rate analysis for a manufacturer. You're only looking for the defects, the ER and inpatient events that you were not able to avoid. And the idea is to reduce those events by more than the cost of the program designed to reduce those events. This can also be done for procedures and tests, as I'll show, simply by counting and dividing by 100. How do you count them? Well, you take ICD-10s, primary coded for all 5 common chronic disease categories, and you simply count the number of events in every year that are ER, observation, or inpatient. This is from the data extraction template used by the Validation Institute. It's yours for the asking. If you want to validate, you got to come back to us, but anybody can look at this. We just today, as a matter of fact, validated an organization for doing this. It did a nice job. You will get a result like this. I don't expect you to be able to see it, but each of these categories for as many years as you have will have a certain number of ER events and a certain number of inpatient events. And we add that up for total events. And then we divide it by the 1,000, or we do it per 1,000. And we get an event rate per 1,000. So the left axis is the number of these ER and inpatient events per 1,000 total belly buttons. The bottom axis is obviously the number of years. And we have it for those 5 common chronic diseases. Now, note that even so-called non-electives fell during the pandemic because people just didn't want to go to the ER. So anybody who claims that they got savings between 2019 and 2021 they would have to decline by more than those numbers. So in this example, if this were a diabetes vendor claiming to have reduced admission rates or ER rates, which I might add Virta does not do, and wisely, they would have to decline by more than those other chronic diseases, a difference of differences. Now, we do this at Quizify as well. This is a perfect example. We do it for procedure rates. Procedure rates, because we don't make any claims about being able to reduce, diabetic admissions by educating people on where all the sugar is hidden. And by the way, just in case anyone's keeping score at home, the sugar is hidden everywhere. If you buy a processed food and it is sweet, it is full of added sugar, period. And we name names. Okay, you want to come at me, Quaker, with your granola bars there, Cliff bars? Come on, I'm here. Make my day. Full of sugar. So in this particular example, just counting the scans, this is another one of Quizify's things that we do is we educate people on the hazards of things that they didn't think were hazardous. In this particular case, we take our CAT scan and MRI questions. One of our CAT scan questions is how much radiation is there in a CAT scan versus an X-ray, and we give people choices. And it turns out CAT scans are just full of radiation. And especially you don't want to do them on your kids. That's much even higher risk than adults. But guess what? How many parents go into the ER and their kids bump their head and they demand a CAT scan, and it's easier for the ER people to give them the scan than it is to explain to them why they probably don't want the scan. And with MRIs, we just had somebody do a testimonial for us the other day on this. When you have contrast media, that stuff gets stuck in your brain. The contrast media is called gadolinium, gets stuck in your brain. Honestly, who knows if that's going to be bad? It's years away before anybody can tell. But we thought it would people might just want to know that this stuff gets stuck in your brain. And so learning things like this, you take the number of events and before and after per 1,000, and you see how much Quizify reduced them by, and that's it. And then you multiply it by the cost, and you can put in your own cost. It's exactly the same as you just saw for chronic disease, but it's for events and procedures. So let's wrap up with a waitlist control, which is what, I'm sorry, I forgot to mention before that the parallel assignment, that was the Indiana study. So I'm not talking specifically about the Virta studies, but the Indiana study was an example of parallel assignment. And what you're about to see, the waitlist control, is an example of what Oregon, what the veterans did, because they only had a certain number of slots to fill. So they filled some, they had some that they could send to Virta, and others were on the wait list. Well, say what you want about the Veterans Health Administration. They're very good at keeping track of data of people who use their system. And that's why their waitlist control was so good. The best known study of that was done in Oregon Medicaid. They increased the percent of poverty that could qualify for Medicaid, but they said, we don't have enough slots, so you have to enter a lottery. So everyone who entered the lottery was participating. They wanted to participate. And half of them got it and half of them didn't. And then they surveyed afterwards, and they found that there's basically no difference in outcomes, but that the people who had Medicaid had vastly lower stress levels than the people who didn't. So it's a very interesting finding. And I have to say, before we wrap up, so this is a checklist of how to ask how your diabetes or other vendor measures outcomes. And there are 3 invalid ways and there are 3 valid ways. Parallel assignment, Virta, yes, that was the Indiana University study. Boys and girls, don't try this at home. You need an IRB authorization for it. It's a pain to get, but just know that that's what they did. Total events and procedures, that's what Quizify does, and the Validation Institute. A waitlist control, that was the Veterans Health Administration or the Oregon study. And then the 3 things that you have to watch out for are, we took the highest cost, highest risk, highest HbA1c, heaviest employees, and they all went down as a group. Participants versus non-participants, and then the magical, or the versus trend. As soon as you see it, you're done. So 3 questions to ask besides about what methodology they're using. Are you validated by the Validation Institute? And they will say, no, but we hired some independent actuaries to validate us. Well, guess what? When you hire them, they're not independent. Okay. And if so, they should offer a financial credibility guarantee, just like the Validation Institute does, or back it with $100,000 like I do. Or else it's just bribing actuaries to say what you want to say. And I've got plenty of examples. If this were my webinar, I'd be naming names. I just don't want to embarrass my host. And anyone can write to me and I'll tell you the names of these folks. I'm not shy. And then the final question is, if someone were to ask me about your savings claims, what would I say? Because I have to tell you, for Virta, they actually came to the Validation Institute and they said, we want Al Lewis to be part of the validation. So Benny and Linda called me and I said, no, they don't. And so they called back and said, yeah, you probably don't. And then and Jonathan called, said, no, I insist. And I went, fine. Like what you say when you really, don't want to do something, you kind of just want to agree to. And I thought they were just going to go the way of every other validation, every other diabetes vendor. But I was 180 degrees turned around, enough to put my own money on the line. And that is why, my friends, having invalidated other major diabetes vendors, I now offer this $100,000 in support of Virta. And in the last 25 minutes, well, actually the last 50 minutes, you saw why.
Wonderful. Thank you so much, Al. That was really excellent presentation. I think we will have all of our panelists turn their video back on. I invite everyone in the audience to type in any questions that they may have into the Q&A, and we'll spend the last 11 minutes here doing a little bit of a moderated Q&A session where I will moderate. And I thought I would start by turning it back over to Benny, since it's been a while since you last spoke. And we'll wake you back up. And I'm just curious to hear, I mean, obviously we're excited here at Virta about what the Validation Institute is doing and shining a light on valid methodologies. I'm curious if you can say more about what's been the reception and reaction from employers and health plans to what you guys are doing, and is there any pushback, or what has been the general reaction among the employer and health plan community?
Well, in the employer and health plan community, they've been very open because we are forcing that transparency and showing what the good companies are doing. And in fact, just the other day, I was talking to a health plan that you'll be hearing from soon about Virta, because they were evaluating a diabetes solution and asked about 3 different companies, and we gave their honest answers, and we gave them your validation report. And so they're very open to it. They call us all the time asking questions and asking us to explain the validations to them. So we're very excited. For the people that are listening, if you have questions, you can always email us, call us. We will gladly walk you through any validation.
Great. Thank you, Benny. Question for you, Al. You talked a little bit about what not to do in terms of designing a valid methodology, as well as what to do, and in particular focused on the diabetes space, how vendors other than Virta are kind of on your naughty list, so to speak. Could you say more about anything within the diabetes space specifically, of what you've seen as some of the tricks or misleading methodologies that some of the other vendors have used?
Okay, it would require naming names, but I won't give an opinion. I'll just go with factoids. Livongo. If you read their study, you will see that what was done by their employees and consultants and suppliers, and it was published in a so-called open access journal where you pay to have things published. They did peer review though, and they changed the language of Livongo drove savings to Livongo was associated with savings. Those were the exact words. If you read the press release from Livongo, it uses the word drove. Now, I'm not going to give you my opinion on that. I'm going to ask you, I'm just simply going to say that's a fact. Another fact about Livongo, and you can Google on Livongo and Better Business Bureau. Well, let's just let you Google on Livongo and Better Business Bureau, and you can see for yourself what they say. And I will also tell you that the Amazon review for Livongo, the last one before Amazon took them down, was a 1.6 on a scale of 5. Okay, those are all facts. Livongo's welcome to sue me, but those are facts with screenshots.
All right. Thank you, Al. Let's turn it over to Frank, where I have a question for you, sort of around getting at the populations that do well in Virta versus are there any that don't do well? A person was asking, is the results among our VA population and our clinical trial population, how transferable is that to commercially insured populations?
Well, so I guess I would start out by saying that at this point in time, when we've looked at broader populations now in our book of business, where we broaden the age and broaden the demographic, that we're seeing very comparable results. And so I don't know that there's anything that I can really speak to in terms of a demographic that I think would be more or less appropriate. The thing that's been really clear, of course, is that this is a lifestyle change. And so the people that are coming to us are self-selected. This is an opt-in solution, whether we're dealing with employers or with health plans. And so we understand that this is a member choice issue. And so I think from my standpoint, if someone is educated about what we do and how we do it, and they're interested in it, they have a high likelihood of seeing metabolic improvement.
If I might just add a biostatistical flourish to that, they will self-select into a program and you will show better results than you saw in the actual controlled study. But in both controlled studies, both the control arm or the wait list and the actual people both self-selected in to the pools.
Yeah. And I think a related question that we're seeing here, Frank, for you as a follow-up, is maybe to further underline the difference that a patient might see and experience going through a diabetes reversal treatment, specifically Virta, versus some of these other diabetes management programs. What's different about it fundamentally from patient experience, from an outcomes perspective?
Well, I think there are a number of differences. I mean, the first is the medical nutrition therapy. This is a different approach and it results in different outcomes. That's what the research for the last 40 years has shown, that this particular approach with carbohydrate restriction to a level that is appropriate for that person metabolically makes a profound difference in glucose control and the need for medications. That's what the American Diabetes Association said when they listed this as a first-line therapy option, citing our research. They said there's good data to say this makes a difference, this nutritional approach. That's different than what I was taught to do in managing diabetes. It's different than a lot of people will see in a management solution. The second thing, Al had a point to add.
Yeah, I just said very apropos what you said. The reason that you were taught that way was that the sugar industry bribed the Harvard School of Public Health to demonize fat at the expense of sugar, and sugar would be okay. And not only that, came out like 6 years ago. I myself personally took a course in nutrition from the guy who was bribed. So I remember sitting right there taking notes. Sugar okay, fat bad.
I don't have anything to add to that. Yeah. So
Yeah.
The other thing that I would say that's very different about our approach is the way that we utilize technology to actually help with a very intense interaction with the team. It allows us to support people in lifestyle change. We know that lifestyle change is very challenging for people. And one of the best ways of achieving sustainable lifestyle change, at least in theory, is number one, seeing results that are meaningful. So you feel like the work that you're putting in is actually accomplishing something. And two, that you have real-time support when you need it. And so one of the things that's so different from what I experienced as a PCP, I would see people every 3 months or every 6 months. I would see their laboratory results. Maybe they were worse. And then we're trying to backpedal and understand what happened. In contrast, if you have a coach, quote, in your pocket 7 days a week, who's looking at your numbers in real time, it's not waiting 6 months to say what happened. It's instead saying the numbers are a little bit different today. Let's talk about that. Let's understand that a little bit more. What is your body teaching us? What is it telling us? And what are the options going forward? So it's a very different level of support, taking advantage of the technology that's now available.
Right. And one thing I would just underline what you said, Frank, that's different about diabetes reversal is the ultimate outcome is patients are controlling their blood sugar while getting off of their medications, versus with diabetes management, you're controlling their blood sugar through medications by generally getting them to adhere to these glucose lowering drugs like insulin, which are often very high cost and come with a variety of side effects. And so For people who are going through reversal, it's really wonderful that you can achieve blood glucose control while getting off of all those high cost drugs. And speaking of drugs, another question I'll send to Al's way is around the Virta savings model, which the Validation Institute looked at drug cost reduction as opposed to medical cost reduction that result from the Virta treatment. And there's a question around, is there anything that's more valid about what you like? Why did you look at the RX costs specifically? And is there anything that's like more valid as you look at the RX impact of Virta as opposed to medical cost reduction?
Well, the medical cost reduction would have to be based on an admission cost reduction. One of the classic trivia questions that I ask when I do trivia contests and conferences is, what is the admission rate per thousand in the under 65 insured population, primary coded to diabetes per thousand? The answer is 1. So it's essentially impossible to reduce that number. And often that is an admission due to people trying to over control their diabetes with meds. So that's thing one. And thing two is that the cost of insulin, as you mentioned, is very high. And you can actually make, as Dr. Dumont and you folks have shown, make changes in a fairly short period of time that reduce that amount. The other thing, just to put just because I'm obsessed with validity here, earlier, my esteemed colleague said that you folks save $280 per member per month. It's $280 per diabetic member per month using medication at the beginning of the period.
Okay, thank you. Okay, and I think we have time for just one more question, and I'll turn this one over to Frank, which is around sustainability. And the question is, for people who successfully reverse their diabetes or put into remission, are they susceptible to relapse? And how do we think about the language around reversal versus cure?
Well, so I'll start out with the last point, which is that we're very careful not to talk about cure. That people have a metabolic condition, insulin resistance, glucose intolerance, however you want to label that does not go away. And so someone needs to sustain the lifestyle changes in order to sustain that level of success. Now, we talk with patients very early on about what that long-term success is going to require and what it's going to look like. But the bottom line is that everybody is susceptible for relapses with regard to behavior change. That's part of the reason why some patients continue to work with us beyond 1 year, beyond 2 years. We have some patients that have been with us for 6 years because of that level of ongoing support that helps them do that. There are patients that do leave the program and that do have that relapse and then return to us to work with us again. So what we know is that that's got to be one of our goals, is that long-term sustainability, and we try to equip people with all the tools that we can and the support to help them achieve it.
Wonderful. Well, thank you, Frank. Thank you, Al. Thank you, Benny. Thank you for everyone on the line who joined today's webinar. Again, we will be sending the recording out to everyone who registered. Really a super insightful conversation about the iron triangle of digital health, validation, ROI, and sustainability. I think we hit all 3 of those today. So thank you all, and hope to see you soon.